Mulai deh, Ben.
Okay, I think almost 50, right? Right. Good afternoon, colleagues. Good morning to some of our panelists. Thank you so much for joining us in our 25th FARO webinar. Our topic for today will be winning the fight against cancer. We are going to discuss about radiotherapy and the comprehensive cancer control strategies. With us this afternoon, we will have Dr. Cherian Varghese, the coordinator for NCD at WHO.
Halo.
Hello, everyone. Thank you.
We also have Professor Soehartati Gondhowiardjo. We all know her. She has been very active in the field of cancer control and championing radiation oncology in the bigger picture of cancer management strategies, both in Indonesia as well as globally. She has been actively working with WHO and IEA in various initiatives, and she will share some of her experiences and perspectives on integrating radiotherapy and comprehensive cancer control program. And also with us, we have Professor Tomoaki Tamaki. Currently, aside from chairing the FARO Leadership Development Program Committee, he's also a full-time professor at Fukushima Medical University in Japan, and he has been working together with IEA both inside and outside. And he is also a member of the RCA Program Advisory Committee. Also, we have Dr. Sonali Johnson. Welcome. She is the head of Knowledge, Advocacy, and Policy for UICC. She has worked on a range of public health issues, not only cancer control, but also HIV/AIDS, gender equality, reproductive and sexual health, various other topics. And we hope that this broad perspective will benefit the discussion as well. Also, we have Dr. Jen Mossman, is Cancer Survivors Advocacy Group expert from the United Kingdom. She has been working on various aspects as well, from rare diseases, supporting cancer trial program, and coordinating UK Committee for Cancer Research. She has been involved in several nice appraisals of cancer medicines, the not so nice, right? So thank you so much for joining us. So to start our session this afternoon, I would like to invite Professor Imjai Chitapanarux as the President-elect of FARO to give some opening remarks. Please, Professor Imjai.
Thank you, Ben. Good afternoon, good evening, and good morning somewhere. Welcome to the 25th FARO webinar in the theme of winning the fight against cancer and radiotherapy in the comprehensive cancer control strategies. I'm so glad that IROS bring this topic to FARO webinar. According to the Global Can 2020, there was a substantial burden of cancer incidence and mortality in Asia. Although there was a decreasing trend in cancer mortality, but its incidence had been increasing, especially among female and younger population in Asia. So on behalf of FARO, I'm also glad to have both speakers to share their invaluable expertise, experience, and insight to us in cancer control strategies. We FARO hope to do much more, a step further with the Cancer Plan for Asia, and joining forces, working in partnership together to bring about change. And thank you very much for this webinar. Thank you all.
Thank you, Professor Imjai. Before we start, shall we take a group photo as usual? I can see Dr. Supriya Chopra as well here. Welcome. Professor Nagata, thank you for joining. Dr. Andika, please let us know when you have taken the picture.
Okay. Dear respected Prof and Doctor, my name is Dika from Aurora, Indonesian Radiation Oncology Radiation Associate. First, I would like to thank you for joining our webinar today. Now I will assist you in taking our group photos. The picture will be taken twice, so kindly turn on your camera and please hold still for a brief second so we can get a clearer picture. Okay? 1, 2, 3, cheese. Okay, once more. 1, 2, 3, cheese. Okay, back to you, Dr. Ben.
Thank you, Dr. Anika. We really appreciate IROS technical support and active participation for our webinars. Okay, so to start our webinar this afternoon, we will have our first speaker, Dr. Cherian Varghese, who will share some perspectives on challenges and strategies for successful cancer control program. Dr. Cherian Varghese, as I mentioned earlier, is the coordinator for management of NCDs in the WHO Department of Management of Non-Communicable Diseases, Disability, Violence, and Injury Prevention. He is responsible for the overall guidance and program management related to NCD management, involving multi-sectoral plan development and research. He has published over 70 articles in the field of NCDs. Thank you so much for joining us, Dr. Varghese. The time is yours.
Thank you. Thank you, Dr. Ben, and greetings of the day from WHO Southeast Asia Regional Office in New Delhi. Thank you, FARO, for organizing such a wonderful webinar topic, winning the fight against cancer and the importance of radiotherapy. I started my career as a radiation oncologist, even though I drifted into various areas, but my heart is still with radiation oncology. I hope you can see my slides. I'll take you a quick detour of what is the sort of landscape. Many of you are experts in this area, and also many who have joined would have good ideas, so I will not take too much time. The global snapshot is that the cancer is the second leading cause of death globally, responsible for an estimated 9.8 million deaths in 2021. What is interesting is that the high incidence is there in high-income countries. That is because of various factors. The incidence is relatively low in low and middle-income countries, but the mortality is very high, which certainly is not a place to be in. 70% of the deaths occur in low and middle income countries. Also, populations are very high there. A lot of risk factors are there that we all know. They have to address risk factors, especially tobacco, since it is one of the leading cancers. We did a paper on 20 upper middle income and high income countries to look at the change in mortality between cardiovascular disease and cancer. And it clearly says that the decline in cardiovascular disease is substantial, whereas cancer is to catch up. So I think the importance of cancer as the leading cause, replacing cardiovascular disease, is not very far in all parts of the world. We have to reduce risk factors. As we know, this is the European code, but we are also working with IARC on an Asian code for cancer prevention. But what is important is prevention has to start early. It has to be easy, enjoyable for everywhere and for everyone, because the risk factors are so highly prevalent. And the latest introduction of HPV vaccine is going to be a game changer in this, as we can see. If you take Southeast Asia region, which is up to Indonesia in the WHO Southeast Asia region, and if you look at incidence and mortality, it is very high. The MI ratio is very high, showing that the cancer care as such is not up to the mark. It's almost 50%. So we need a lot of work to be done. And again, as we heard, cancer in women and cancer in young people are on the increase. The current scenario, this is a very broad sweep. I'm sure there are many participants represented here who are doing great work in all these areas, but primary prevention is not really big time. It is still sporadic. Early detection also has not reached a very high level of coverage. Mostly it is opportunistic. Diagnostic capacity and human resources are major weakness, leading to late stage presentation. Average presentation of even the most accessible cancers are in late stages. Then, of course, it is the beginning of the end, because once it is late stage, then whatever gimmicks that we do, outcome is going to be much less. So I wish to say that it is not cancer which causes death. It is the delay in cancer management that causes death. So there is a delay at all levels that we have to address. WHO does a global capacity survey looking at pathology, cancer surgery, chemotherapy, radiotherapy, and you look at low income countries and look at the proportion of radiotherapy publicly available, it's only in about 30% of countries, compared to high-income countries where it is 90%. So there's a huge amount of work to be done if we want to have optimal cancer care. So how do we start all these things? One of the first things to do is to have a good national cancer control program. The basic idea is to do more with less, because there is never enough resources to do all the aspects of cancer control. So a national cancer control plan or a program is the rational means of achieving a substantial degree of cancer control. It should cover all aspects, as we all know, from prevention to early detection to treatment and palliation. We need to set priorities. We cannot do everything. See, unlike TB or malaria, which are a single disease, cancer itself is more than 200 diseases with many subtypes. So it really shows success in some areas, and then success will breed success. We recently did the National Cancer Control Plan, supported Maldives for that, and they have a very clear strategy to reduce the incidence of mortality from cancer through strategic objectives like prevention, early detection, evidence-based treatment without financial burden, which is important, expand coverage of palliative care, having registry and conduct research, and supported by various other implementation considerations. So that is one of the recent examples of how to optimize the national resources. If you look at an average person in an average country, from the onset of symptoms, it takes almost 8 months when that person actually starts proper cancer control or cancer focused care in a hospital with all the facilities, with so much of back and forth. And this is something that we really need to address, and it can be addressed through starting an early detection program or having a population-based screening program if the country has adequate prerequisites. Look at the example of early diagnosis impact from the United States. It's a very long period, 1950 to 2000. So early diagnosis, improving no cancer screening. Look at the mortality incidence ratio going from 0.4 to about 0.28. Mammography was introduced here. After mammography and with adjuvant therapy, the reduction is much less than what a reduction in stage at presentation could bring. So that is one of the key messages in terms of getting cancers early and having adequate treatment. Screening, everybody wants to screen, but then it's a huge effort. Screening means you have to have substantial number of people being treated to be screened. And then what about the screen positives? Do we have the system capacity to absorb all of them, do the diagnosis and adequate management? And what do we do with those who are sort of borderline? So one has to seriously consider the country's capacity before we start general population-based screening. I always say if the capacity of the health facility is like that, then that is not the place to bring in a mammogram. So one has to really match what is possible, and then optimization will be my key word, I think, in this whole thing. And then, as you may have seen in the WHO Global Cancer Report, before coming here, I was in Geneva for 7 years when this was developed. We actually looked at all the aspects of how to manage cancer, including coordinated and continuous care, timely and affordable therapy, a comprehensive approach, adequate capacity for health professionals, and for shared decision making, with standard protocols. I think that is so important to contain cost. And we are actually doing a lot of expensive palliation. I think as radiation oncologists, we should be very careful not to do expensive palliation. We can actually do much cheaper and effective palliation. You all know about the choose wisely or choosing wisely elements of the cancer control journey. At every part of the cancer control journey, starting with demonstrating something, scaling up something, establishing cancer registries, doing research. The journey is not just a one-day business. So one has to be prepared for a long-term plan and then make sure things happen. I just want to highlight 2 or 3 major global initiatives which all of you are aware. One is elimination of cervical cancer as a public health problem. Even with all the sort of things in the armamentarium, like a vaccine, an early detection strategy, a screening strategy, and good cure rates with good treatment, we still have a large number of deaths from cervical cancer, which is unacceptable. So WHO has come up with this thing and an interim set of targets to achieve 90% of girls to be covered with HPV vaccination, 70% of women to be screened and treated, and 90% of women to be treated for invasive cervical cancer. And the threshold is to get to less than 4 cases per 100,000 women for cervical cancer, which is not the case in most parts of Asia. The average incidence is about 15 per 100,000. We also have a global breast cancer initiative, again, to reduce the global breast cancer mortality by 2.5% per year. Here again, we have all the pillars of health promotion, early detection, timely diagnosis, and comprehensive breast cancer management. So these are some of the things where there is social acceptance in actually making this difference. One program that we are sort of really advancing is childhood cancer, where again, the target is to get a 60% survival from most of the common childhood cancers, which is less than 30 in many low-income countries now. So this is the Global Childhood Cancer Initiative. Within the WHO Southeast Asia region, you may know about the example of the National Cancer Grid of India, which has made a huge impact with more than 250 institutions under the grid. So we are developing it as a Southeast Asia Cancer Grid, covering major hospitals from the Southeast Asia region, and then to develop uniform standards of care, capacity building, networking, and policy and program support. And as we know, whatever we do, there will be still patients that needs to be given good quality palliative care with honesty in communication. We need a lot of CAT scan. I think communication is completely going out with all the kinds of new technology that we have. We have developed the WHO guidelines for cancer pain management, where radiotherapy is a major set of recommendations are available, and you can see that. Now, how do we organize services? This is the last part of my presentation. So if you look at cancer care in a country, it depends on the level of healthcare, comprehensive care, oncology unit in a medical college or a subnational hospital at a local level hospital. Then we have to see what are the prevention services, diagnosis and screening services, referral care, and others, palliative care, that needs to be looked into. So some sort of a matrix of service care delivery has to be thought through in countries. That is very important. And for example, in parts of India, the Tata Trusts are exactly doing this as level 1, level 2, and level 3 centers, and connecting them so that people get access without any delay. We worked with the IAEA and developed this book called Setting Up a Cancer Center. The main reason was that a lot of money is wasted in cancer by setting up huge buildings and unnecessary machines which never gets used. So WHO has the list of priority medical devices for cancer management and guidance on how to set up a cancer center. IAEA, as all of you, especially Prof. Soehartati, is part of all these things. You know that very good guidance. So the message is use evidence-based and locally relevant machines and technology and optimize resources. Fancy machines and fancy stuff is not going to make impact in cancer. We also developed a roadmap towards national cancer control programs where radiotherapy milestones have been listed. That can be also useful guidance. But most importantly, unless we have good data on cancer, we are not able to plan well or evaluate well. So we need population-based cancer registries where we get good incidence and mortality. We need hospital-based registry to see what is the quality of care, completeness of treatment, and other aspects. And there are special purpose registries that needs to be set up depending on the exposure and others. Finally, leading to change in incidence, change in survival, and change in mortality. We also need a lot of research. I was calling my radiation oncology days when we did hyperfractionation in carcinoma of the cervix, or looking at which type of neck nodes are amenable to treatment, or even looking at stage-based survival. But I don't know, I'm not very much into the field. I think the research in radiotherapy and related areas are relatively less now with the onset of various other therapies. But I think radiotherapy is being a mainstay of a lot of cancers, epithelial cancers and others. We need a lot of research in this area as well. And the cancer centers should be known by their site-specific survival. So moving forward, use best buys, which are the proven cost-effective interventions. Prioritize. All components and all interventions cannot be taken up immediately. Contextualize. Machines and processes in a high-income country may not be immediately relevant. So a locally relevant practical national plan is needed. Sustain interventions. As I said, it's a long journey. So it is not limited to one campaign or 1 week program. And an incremental increase. So there are no shortcuts to any place worth going, but I'm sure Prof. Soehartati and group will take it far. So thank you very much, and thank you for giving me the opportunity.
Thank you very much.
Thank you very much, Dr. Cherian Varghese. You highlighted very important points there, highlighting that NCCPs are important because individual situations are different in various countries, and no intervention can be suited everywhere in the world. And there is a great need for local relevance in devising the strategies instead of just buying fancy machines. Those are, I think, very important to understand by our stakeholders as well. And that I like the statement that the cancer centers should be recognized by the results, not their gadgets. So I think that's very important. Thank you so much for the insightful talk. For our audience here, I would like to remind that you can type your questions at the Q&A box, and our speakers and panelists will do their best to answer. All right, so next we will move on to Professor Soehartati. She will share some of her perspectives on integrating radiotherapy and NCCPs. As you know, Professor Gatti has been actively involved in this field, and I think it's going to be very interesting to hear her perspective as well. Prof. Gatti, the time is yours.
Yeah, thank you very much, Ben. Allow me to share my screen. Can you see my screen, Ben?
Yes, I can see it.
Yes, Vic.
We can start.
Moment. Yeah. So thank you very much. Good afternoon, everyone. It's a pleasure for me to have a chance to share my talk in this topic, integrating radiotherapy in comprehensive cancer control program. I hope that this talk will inspire and motivate everyone here to remember for taking a bird's eye view of what is going on in the fight against cancer, to advocate that radiotherapy is a crucial part, is one of the key for success in NCCP, that we have a big role, not just limited to the practice, but also the comprehensive aspect of cancer control. Yeah, you know, I am radiation oncologist from Jakarta, Indonesia. As Dr. Cherian has given us many wonderful insights of the comprehensive cancer control strategy. So I will start with the radiotherapy role in cancer journey. And then we will look into the situation in our FARO countries, especially about the utilization of radiotherapy, so-called the RTU, and then the gap that we should be aware, and then how we should plan for scaling up to close the gap. We will then get back again to the comprehensive cancer control plan and see why our plan for radiotherapy facilities has to be integrated for completing the plan. Just to remind all of us in the very beginning, that's one of our aim when establishing FARO together is to promote the advancement of in status and standard of practice of radiation oncology profession in our region has become one from the diversities. These photos is from 2012 in Tokyo. Then it was the first very beginning of the FARO. It was in JASTRO meeting. And then it was 2014, inaugurated of the FARO in Yogyakarta by the IROS meeting. And then the first council meeting was 2015 in Kyoto. Now, talking about the cancer journey is already mentioned with Dr. Cherian. As we all know, cancer journey is a multiple stage which may span through a lifetime, starting from the, as we know all, cancer prevention stage, and then screening and diagnosis stage consists of an early detection, screening, clinical diagnosis, and imaging, etc. Then a treatment stage, follow-up, and survivorship stage, as we follow up the clinical lab and imaging modalities serially from all of our patients. And the last but not least is the hospice care, the end to give a good quality of death for the patient. And the radiotherapy, as we know, is the part of the treatment and also palliative care. But we need to remember that actually we are fighting for the whole process of the cancer journey. Just as a reminder, we could enter the patient journey with different roles as the definitive treatment combined with chemo, neoadjuvant treatment, adjuvant treatment, as well as the palliative treatment. How does radiotherapy play a role alongside of other treatment of cancer? This is a publication from the expert from Australia, France, there from Professor Michael Barton, Prof. Mayling, and the team, is a very trusted publication, showing us globally how is the coverage of radiotherapy, chemotherapy, and surgery in the treatment of several cancer sites like breast, brain, prostate, and this data is globally. We can see here, for example, for breast. So the role of radiotherapy is 87 from all the cases, and the chemo is 67, and the surgery is 97. For just an example in the breast, which is it must show a different data. I think if we compare between one countries or region to others, it depends local factors. For example, case distribution by states, facilities within the countries, etc. Let's say in Indonesia, for example, our breast cancer patients, 70% still come in the late stage. The coverage of radiotherapy in breast cancer in our country will be different compared to, for example, in Singapore. Could be that the situation is another way around. 70% they come in early cases. But what we can see from this data is that radiotherapy has an important role in treating cancer. I like this one, poster from Marie Curie. Maybe all of you have also to really aware that we have this 10 fact about the radiotherapy. For example, we know that a quarter of the patient who needed to be irradiated have no access for radiotherapy. That we, in 2030, if we can fulfill the needs of radiotherapy in the countries, we can save 1 million years of life for the patient. And there is an improved of quality of life, etc. We can see it later. Radiotherapy has proven to give many impact clinically, socially, and economically. The latest report, as we know, that was 2020 from the IROS program, covers this topic very nicely. Which, I was also involved in the writing along with some colleagues in the region. In this region, there are many advancements and improvements happening in the last 20 years with the full support of the IROS. One of the main important areas is increased access to high quality of radiotherapy, as well as increased patients treated with radiotherapy more than doubled, and waiting time is much less. And 84% of the member countries reported that the quality of radiotherapy services improved as a result of participating in the RCA program. It is shown here as well as an introduction of cutting-edge radiotherapy technology, IMRT, 3D conformal radiotherapy, 3D image-guided brachytherapy, stereotactic body radiotherapy, even the particle therapy in 2 countries. And we know that improve the technology, that means reduce the side effect and will increase the radiotherapy result. Workforce. We also been increasing significantly in the region. In 2020, across all the member countries, there were total of 116 educational programs in radiotherapy available, 3,215 radiation oncology department, 94 radiology society, radiation oncology society. And between 2000 to 2020, 6 to 8 additional radiation oncologists, 14 to 60 additional radiation technology therapy, and almost more than 9,000 additional radiation oncology nurses, and more than 6,000 additional medical visits. And what is the clinical impact of this improvement? Radiotherapy service in our region, in the member countries, it is already calculated that 16% improvement of the 5-year local tumor control rate estimated, as well as increased 5-year control rate by 13%. And by 2020, approximately 47,000 health-adjusted life year had been gained cumulatively by cancer patients in member country from additional radiotherapy treatment attributed to the RCA program. Now let's take a look back to our, countries of FARO. Our region, Asia, is a huge area. The latest data showed that Asia population account of 59% of the world population, and FARO represent 85% of all Asia population, is equivalent with the 50% of the world population. Now, to give you a quick reminder of what is going on in our region and our country, Asia consists of, as we know, the most heterogeneous country in demography as well as in the socio-economic. And in FARO country, we have countries with high income, upper middle, and lower middle income countries, shown here with a different color. And unfortunately, can see here, cancer incidence rate goes higher with higher income countries. We acknowledge that in large part, it's contributed by higher or more advanced report in cases of cancer or cancer registry. So we can say that the better cancer registry, the higher cancer incidence reported, and it is mostly in the high income countries, as it is shown in this slide. And we have a report from Professor Mayang from the Australian. All the countries in the world of the optimal RTU is around 47 to 53%. The actual RTU thought have a very limited, the actual one thought have very limited result. We put here from Malaysia and Philippines, which is included in the IEA paper, and from Indonesia here that's our own data. We have our own study about that. So we could calculate the need and the discrepancy in the current available margin using calculated method from Zubi, Dr. Zubi from IEA, is published 2015. We hypothesize here that the machine can run for 50 fraction per day, 5 days a week, 52 weeks for years. And for the need, we use in the average fraction of 20. Then we can see the coverage of the need of each countries. And some of our countries have passed the needs in terms of fraction to be delivered nationally, is more than 100 here. Some of between 50 to 100%, and still quite many below 50%, including our countries, is 25%. However, of course, this is just in terms of quantity nationally. It doesn't tell us the story about the advanced technology, geographically distribution, financing of insurance challenges. And there are the things that is quite impossible for us to know. For example, what is really going on in Bangladesh or in China? And it is mentioned before, the real of cancer registry data will influence also the result. So we know that we have a global data of access and utilization of RTU, radiotherapy utilization rate, which is launched also by the group of the GTFRCC, Professor Mary Gospodarowicz. And also we know that there are calculation methods that we could run from just knowing numbers. And I just saw from the FARO countries, it serves us as our reference and learning point. Then we need to adopt the method to find out the real situation in our country. We are working on the exact topic under the umbrella of RCA coordinated study, aside from Indonesia, Thailand, Philippines, Malaysia, Vietnam, Mongolia, Korea, Australia is participating too. And of course, we all have our own different situation. The distribution by states of the disease, the stakeholders or decision makers, politics, economic in our country's culture, social environment, how our doctor or health professional act and work, and the public itself. So this will create a unique situation, and therefore we need unique strategies to work on. And I want you as radiation oncologists to take the role as the one who truly understand the need, the patient situation, the challenges, to be advocates in pushing this wherever we are. As an example, this is briefly the result of our work. We found that our optimal RTU is 62% for 10 types of cancer. If we extrapolate to all the cancer, it becomes 55.7%. But when we look to the actual RTU divided the total number patients treated in a year to the data from the Globogan, we will come to the 6.16%. So compare our actual needs from optimal RTU, our current service, so only cover, let's say, 11%. For our case, we have to take into account that the Globocal new cancer patient is just a number. It is not a real world, because it doesn't mean that the patient will come to the medical services. We don't know the real data since our cancer registry is not really produce a good data. If we have a good data, I believe we will have a better optimal RTU close to the reality. The actual RTU is depend on many factors, such as we know all the awareness, readiness, implementation of multidiscipline guidelines, cultural belief, geographic affordability, and of course the number of equipment. And so-called the gap is the discrepancy between the actual RTU and the optimal RTU. Optimal RTU is calculated based on the evidence base, the role of radiotherapy in treating cancer by site. And closing the gap will increase access of radiotherapy service to the public who need it. The data is very important in our own country. For example, in our country, we are archipelago countries consist of 1,000 islands. So there are many factors as well influence the actual RTU. To close the gap, we will need unique strategy involving multidiscipline and multi-sector. And we need to convey this message to our stakeholders, decision makers. That's what we do. We have been the fight against cancer for quite many years in Indonesia. We have faced many up and down, facing a lot of Ministry of Health, for instance, for their own priorities in health sector. And our current one in this matter quickly understand the importance of our message and make cancer one of his priority, including in large scale up of radiotherapy services. In the span of this year alone, he planned to build 12 new cancer centers in various provinces of Indonesia this year. And for the next year, it fulfill all profit. Please Indonesia. And you can see here that the average from 25, as we mentioned before, it will become around 50%. But anyhow, increasing number of radiotherapy machine is one achievement that we are very glad to be working with our Ministry of Health in this year and next year. But only that is not enough. To show against some influence factor in completing the number of radiotherapy machine based on radiotherapy RTU calculation to increase the actual RTU, the awareness and diagnostic, the system, availability and accessibility, affordability, and all of these factors have to be improved in the same time. I'm sorry. Yes, and so it's clear that radiotherapy improvement cannot be progress alone. It should be in the roadmap of National Cancer Control Program, or it will be underutilized of the equipment. On the other way, we can sort it as the 5A. Access, affordability, accepted, accommodated, and availability. It is already measured in Indonesia using our own RTU, as is mentioned before, 25%. But in fact, the actual RTU, that means if we taking into account all the 5A is calculated, so it will become 11%. How is the gap coming? It could be from the lack of our NCCP impact, either awareness or utilization of the multidisciplinary guideline, not yet really well implemented in here. So be aware, it should always include the sustainability and include also human resource development for the sustainability of our improvement of the quality of the radiotherapy. So actually, all the planning and increasing radiotherapy services and access come back to this full circle, back to comprehensive cancer control plan to deliver high quality and safe radiotherapy service with ideal access. It needs a strong comprehensive cancer control plan. And it is mentioned already by Dr. Cherian, what is the National Cancer Control Plan or Program? It's a public health program assigned to reduce the number of cancer cases and death, and also improve the quality of life of cancer patients. Consists of, as it is mentioned, the cancer...
Recording in progress.
Inclusion all element across the cancer continuum framed by the health system and supported by effective financing strategies is very important, monitoring system and quality management. And in the strong national cancer control plan, radiotherapy has to be strongly mentioned and planned. Is even recommended, included from the pre-planning phase. And as well, now setting up radiotherapy service takes several years. So it will also include it in phase 1, 2, as well as phase 3 and 4. So almost in all phases of the National Cancer Control Plan. Good news is all the FARO countries has the NCCP. Thank you to all colleagues who have answered our question. This some has started even earlier than others. For example, China established from 1958. How does this correlate with our preparedness in fighting cancer? The Economist Intelligence Unit have published report on scoring countries index for this, which included sector of policy, planning, care delivery, and health system and governance. Although it does not cover all countries, it only includes 28 countries of the world in 2019 and then 10 countries in 2020. We see here, you can see our rank, and it looks like that it correlates more again with the income level of the country, suggesting that good finance economic infrastructure lay a strong foundation for a country preparedness to control cancer. So a cancer control is always a long run, but please rest assured that a benefit will come. In the long term, we will benefit significantly from winning the fight against cancer. As seen here from Canadian Cancer Control Strategy, the goal is expected to be reached in many years. We see here that they aim to reduce number of new cases and mortality and also increase the survival. To finish, I want to show this hourglass transition phase of fighting cancer. Fighting cancer is about moving through this transition phase of the effort in cancer control. When we emphasize the promotion and prevention, we will first deal with exploding number of cases to be treated at hospital. Because case will be found, this is a good thing, but we need to prepare ourselves. After several times, then we will see the fruit of our effort and see reduced number of cases. Cases will be found earlier, morbidity will be lower, and it is proof already as it is shown in the NCCP from Canada. If we keep our fight in a consistent and calculated strategy, we will reach to this ideal hourglass. And with that, I end my talk today, hopefully bringing new insight and motivation to all of us. Together, we can make it. Thank you for your kind attention.
Thank you so much, Professor Tati. Yeah, I could take some notes from your talk earlier. Basically, I really appreciate the message about installing more machines not being entirely useful in solving the access problem. Yes. It is a solution, but it's only a partial solution, and that a comprehensive one will require other aspects to be addressed, and these aspects will be what is covered in a good national cancer control plan. Yes. And also thank you for the message for radiation oncologists to be champions in advancing access to cancer care.
Yes.
It's a difficult task to do, but I believe that among all of us here, it is a shared idea. All right. thank you so much to both our speakers. And now let's move to our panelists. We have three very high-profile panelists here. We have Professor Tamaki, who has been very strongly involved in some of the initiatives that Dr. Cherian and Professor Tati mentioned earlier, particularly in his involvement in the Regional Cooperative Agreement, or RCA, in various projects in the past. We also have Dr. Sonali Johnson. UICC has been also a very strong champion in advancing cancer care and supporting major cancer control programs as well. That would be very good to get your perspective here. And also from Dr. Jane Mosman, I think your experience in HTA, for example, will be very appreciated. So let's start with our first panelist. Professor Tamaki, do you have anything to add or dispute?
Well, thank you very much, Ben. First of all, I would like to thank the FAROS or IROS organizer for including me in this great panel here. As Ben said, I've been involved with many of the IA projects and also the start of FARO. And I think that from my perspective, the important thing that we need to look at it was what Dr. Cherian has first presented, the under representation of radiotherapy in the comprehensive care, especially in low income countries in our region. So many or most of our effort has been the human resource training and development. Many of the projects from the IAA RCA, which is a regional cooperative agreement in Asia, has been to conduct training courses and many follow-up activities within the national, within each nation by those participants. And I think those training efforts has been hopefully contributed to the improvement of radiotherapy as Tati has presented, and want to go further to in this effort by establishing a FARO. And I think that the strength or our effort has been to create a strong network in our region, and by collaboration and cooperation, strengthening each other in terms of the organization in each of the nations. And that's why this FARO has been the federation of the national societies. And I think that the national society is, in a way, is the driving force in terms of promoting radiotherapy in Asia and in each country of Asia. And I hope that this collaboration in FARO will continue to strengthen our network, and also the strengthen the individual capacity of the each national societies, so that they can improve radiotherapy within the context of comprehensive cancer care. I would like to introduce another effort by FARO, which is to develop young leaders in our regions. And this effort has been started by Professor Tati by initiating the Leadership Development Program. We have we're running the fourth program so far, but the first three has been mostly run by this effort by Professor Tati and her team. And from last year, FARO has established FARO Leadership Development Committee, of which I'm currently a chair. And this year we're making our efforts to run this program by ourselves. and also so that not only that we foster young leaders within our region, but to develop our own capacity to educate leaders. So that's what we're actually working on right now, so that each society will promote the radiotherapy in each region, and also that individuals will become a better leader, not only within the radiation oncology community, but also with creating network with other specialties in each country. Because one of the weakness of radiation oncology is that our presence in the cancer care tend to be the weakest, especially in low income countries. And hopefully that we're able to establish our radiation oncology personnel so that they can be in a good match with surgeons and medical oncologists and contribute to the cancer patients in Asia, I think. And that's my perspective. Thank you.
Thank you, Professor Tamaki. And our best wishes for the important leadership development program which you are leading. Thank you so much. Let's move to our second panelist. We have Dr. Sonali Johnson. Do you have anything to add, Dr. Sonali?
Yes, I do. Well, first of all, thank you very much for the invitation to be here. And I want to also compliment the speakers, Dr. Varghese and Dr. Soehartati, for excellent presentations. I believe they've said all of it, and I can only concur with their views. There are a couple of things I would like to add, which is really important, that's come through in both of their presentations, and which is a very important advocacy priority for UICC, and that is the concept of equity. Equity within countries, equity between countries. And we have a lot of opportunity with global processes at the moment to highlight that point and to bring in the cancer experience of patients, and to bring in the importance of addressing inequity and access to cancer services across the continuum. So, I mean, just picking on some of the points that we've heard, I mean, we heard from Cherian the long delay to the initiation of treatment. So that means for many patients, a potentially curative cancer then changes to an incurable cancer. We've seen from Soehartati the very interesting split in the difference in the calculating the need and the current availability of radiotherapy facilities in countries, and that unmet need. And I just want to talk a little about that, because these inequities will obviously have huge implications on the diagnosis, but then, of course, the treatment decisions. So while it's not about, I agree that it's not about just putting more machines in place, it's part of a global, overall strategy towards investment in the capital infrastructure in a country to be able to service cancer care and to be able to provide those. So there was a commission recently on diagnostics, which UICC was following very closely. And part of that had data from the IE showing that the mean number of people served by one CT scanner in high-income countries are 25,000. In upper middle-income countries is 79,000. In lower middle-income countries, 227,000. And in low-income countries, 1,694,000 by one CT scanner. So clearly, you know, we have, and this was for conditions broader than cancer, but this is really worrying, because if you don't have the investment in the infrastructure in place, you don't have the diagnostic structures in place, you cannot do accurate staging for cancer. And staging is what guides initial treatment decisions. Without the staging, then the treatment is really a guess in many cases, to be very frank. So from the talks and discussion that we've heard, it seems that the key advocacy messages that we need to be saying to our own countries, but also in the region, is that Countries need a comprehensive and budgeted national cancer plan. We've heard that, which sets out the vision, goals, objectives, priority areas, but also benchmarks for infrastructure and equipment. So the imaging example was one, but there aren't really guidelines for how, what is the recommended benchmark for all of the aspects of equipment needed for across conditions, including cancer. What are the programs that are needed? What are the indicators? There needs to be an investment in cancer centers with the referral networks into the community. And Dr. Varghese had given the example of this of a care system in India, where you have a decentralized model with strong referral. That's very important. That then reaches into the primary care network. We must still invest in primary care, including for cancer, because many cancer programs, including prevention, early diagnosis, can be carried out at primary care level. Investment in that human resources for health for cancer. So looking at the skills distribution, the training, it's great to hear about the Young Leaders Program Dr. Tamaki just mentioned. These are really important initiatives to incentivize people to enter cancer, but also to reward them with career opportunities and all the things that are important in a health system. And actually, I just wanted to say, I do have some other remarks on how we can maximize the global health, policy pushes at the moment. So this month, so in September, will be the political declaration on UHC. And we have indications that in the draft that's being under silence procedure now, cancer is mentioned, where UICC has been pushing very hard for the mention of cancer individually in the political declaration, and it's there. So I hope it goes through to the final version. We think so. The fact that it's there is important. It shows the overall burden of cancer. And that's a very good advocacy hook in our countries to say, here we can see how many people are dying per year from cancer, and yet there isn't that investment in the infrastructure required. So how can we then use some of these things that we've learned, the advocacy messages, to link with the UHC discussion and use the National Cancer Control Plan as a guide? So the National Cancer Control Guide is a very strategic document that can help guide the decisions around what is included in the essential benefits package for UHC. Just another point I'd like to make, in addition to what we've heard, is the importance of building efficiency into the cancer control system. And some work has been done on this by one of UICC's members, Orcan International, where they're collecting case studies from different countries. So efficiency means delivering the best possible health outcomes using human, financial, and technological resources available, focusing on what really matters to people with cancer. And there are some principles and values that we can think about in our own national context when thinking about efficiency. So these include being people-centered, promoting shared decision-making, better communication, with patients, but with the different parts of the health system, developing digital health tools, strengthening health literacy and health awareness, then strengthening healthy detection diagnosis through evidence-based screening programs in line with WHO guidelines, investing in diagnostic capacity. So I've mentioned that. Looking at integration with other health areas. What are the opportunities working with communicable disease colleagues, women's health and child health colleagues, promoting access to prompt multidisciplinary treatment through the well-defined referral system with guidelines in place, ensuring access to holistic, supportive and palliative care. And as was also mentioned by the speakers, implementing data-driven learning systems. So including different sources, including population-based cancer registries, but also patient-reported data. So these are some of the, efficiency principles that we can start to look at as well to maximize the use of the resources, financial, human, and capital resources in a country, and to avoid this siloed approach, which none of us want and isn't really good for any of the health outcomes we desire. Thank you.
Thank you so much, Dr. Sonali. And again, thank you so much for UICC's continuing effort to put cancer on the global agenda. note taken about the importance of efficiency in NCCP with the various dimensions you mentioned. And I think this brings us nicely into our next panelist, because Dr. Jean Mossman has been very much involved with both patient groups, basically about the dialogue component of NCCP, and also about what the HTA. So, Dr. Mossman, do you have anything to share with us?
Okay, thank you. Well, first of all, I want to congratulate FARO. This sort of opportunity to share experience and knowledge, I think, is really important, because if we want to move cancer care, then we need to ensure that everybody who's delivering it is well informed, educated, etc. And I'm Prof Tati for several years now, and I know she's been very active in this field. So it's really good for me to see that it's a much broader community working together. I have a few thoughts about what I've heard today. The first is that we heard a lot about late diagnosis, and it seems to me there's a huge piece of work still to be done about awareness of cancer, the fact that it can be treated effectively, that there are good outcomes, but that you do need to see somebody who is an expert in treating the illness, etc. I know from working with patient groups in Asia that many patients still see the sort of local healer as such. And I've heard patients tell me that their effective treatment has been delayed for years because they've continued to see a local healer rather than get the appropriate care. So I think there's a big piece of work to be done about that awareness. And I'd want to extend that to awareness about radiotherapy, radiation oncology, because most people, when they kind of talk about cancer care, etc., they talk about chemotherapy, but actually radiotherapy is way more widely used and applicable. And I think, we've got a big piece of work to be done to explain about the role of radiation oncology as being a very effective tool in treating people with cancer. The second thing I want to just pick up is that in your national cancer control plans, I think there needs to be something around the role of the multidisciplinary team. If you don't have that multidisciplinary team looking at what's the best treatment pathway for a patient, you can lose patients. They won't be referred for radiation oncology because they're not being considered appropriately. So I would want to have the MDT built into every national cancer control plan so that we ensure that patients do get evidence-based treatment, and that includes radiation oncology where it's appropriate. As we've already seen, it has a role in right through the pathway of cancer care, from early treatment through to palliation. So I do think that the MDT is quite important. I think the next thing I would say come up already is the importance of resourcing your national cancer control plan. It's great something on paper that we can stick on the wall or we can carry around and everything. If we don't have the commitment of resources, then it's never going to be delivered effectively. And those resources are staff, of course, the equipment we've heard about, but also the materials to support delivery of cancer care. I think there's a very broad spectrum of resources that are needed that we should not forget. My next comment would be about partnerships. And again, this is where I've been with Prof Tati and working with patient groups, health physicians, etc. When I do a lot of work with patient organizations, and I always try to explain to them that one of the biggest challenges for governments, for HTA bodies, etc., is uncertainty, because the radiation oncologists say one thing, the nurses say another, the medical oncologists say another, the patients say something different. So you create uncertainty. And I think you've got to work with all relevant partners to make sure that you're giving one message that's ignored. Because with uncertainty, it's an opportunity for the government or payers to just say, oh, you can't make up your mind, so we're just not going to go with this. I think data is critical. how can you plan your cancer care if you don't know the number of patients? So the idea of a national registry that is comprehensive, that's effectively funded, and that is measured, I think is really important. I think you can use to monitor what's happening. So it's not just recording cases, but it's recording outcomes. And I know in Sweden, for example, their cancer registry captures what they call quality of care. So what does the patient get in terms of care, as well as what the outcomes are? So I think, you can look a bit more broadly at your data. And the final thing that was mentioned was health technology assessment, which I think the one piece I would say is to ensure that the people who are the recipients of any treatment, the patients and their family and friends, are involved in any HTA process. Because what you see is that most decisions are made by health economists, and they have no real idea of what it's like to live with cancer. They read a piece of paper where N equals 27 as the number of people in a clinical trial, but they don't have an understanding of what it's like to wake up in the morning, to live with your cancer, the treatment, the side effects, the long-term effects, etc., and go to bed with it every day of your life. So I think if you want things like HTA to be responsive, you've got to make sure that you're engaging the relevant individuals in collating your evidence to HTA process. I think you've clearly still got a lot to do, but it's like eating an elephant. It is one bite at a time. And I look back to my experience in the UK when I first became involved in cancer advocacy. Our delivery was terrible, but we put in place a comprehensive strategy. So we now have cancer centres. People are seen by experts in their illness. We capture what treatment they're getting, etc. So we have a much better system. And I think that's a result of everybody working together to say what we've got is not enough, it's got to change, and pushing for that change to happen. And that's what I think you guys can be doing. So thank you.
Thank you so much. Very insightful comments, and it really enriches the discussion this afternoon. So what I can take note there is that, well, Dr. Cherian very nicely summarized the statement that not everything that counts can be counted, right? So that's really important. And the importance of involving the recipients, the patient groups in everything we do, especially when we talk about HTA. I think we have a really real experience here with Prof. Tati when there was an HTA about trastuzumab, and that caused a problem with the patient groups. So I think that is something that is very important as well. Right. So thank you so much to our speakers and panelists. We actually had one question from the audience. I would like to invite the audience for more questions, actually. And this has been answered, but let's discuss this further. There was a question about community intervention. Will it bring a meaningful impact on improving the behavior of cancer patients and acceptance of radiotherapy? Because we know that behavior is very unique in each region. The communication pattern is different. The priorities are different. So let's expand this question into a discussion on how do we design a community intervention. This is open. Oh, Dr. Sonali, yes, please.
Yeah, I'm happy to start. I think this is a very interesting question, and it's one that we've been looking at UICC and linking to emerging work that we're doing on health literacy in relation to our breast cancer program, for example. One issue that we feel is really impacting on uptake of cancer services is cancer stigma. So it's the perception of cancer in a country. what we've found in looking at some of the data is that we've spoken to some of our members, we've looked at the literature, and there's a compelling argument to be made that the higher the mortality rate in a country, the higher the level of cancer stigma. And I think I don't have data to back that up. It's really about talking to various people. It's difficult to measure stigma. There are some indexes that are being developed, but basically the argument goes like this. The more you see people dying from cancer, right? The more you see people going into a hospital that have a suspected cancer and then coming out dead, and then you go to many funerals, etc. There is a fatalism attached to cancer, that cancer automatically means death. And therefore, the early detection possibilities and the treatment possibilities that do exist for cancer are not getting through because people are just afraid of the disease and they don't want to know. So then the coming forward to a health provider for any suspicious symptoms becomes delayed. And there's also the societal view of cancer. There are myths and misconceptions about cancer. I have spoken to people in the region, including this region, where people may feel that cancer is contagious. People who have cancer are asked to eat separately from other members of the family. People don't believe that there is effective cancer treatment and go predominantly to traditional healers. So I think one of our interventions needs to be to address cancer stigma. And there are ways to do that. We have World Cancer Day, for example, as an opportunity to talk about cancer in a transparent, fact-based, informational way. Work and survivors of cancer. That's really important when people see people who are living a good quality of life, living with cancer, or are in remission, or who have survived cancer. That's also psychologically important for the community. And we should be drawing on patients to help us and cancer societies with that kind of work, whether that's through public events, engaging celebrities and other things to really talk about cancer more in the public. So I would say one of the ways, from my view, to address this question is to address stigma.
If I may just add a bit,
Yes.
In addition to all what Sonali has said, which is so critical, I think we also have to look at the provider side. The recipient side, of course, there are a lot of issues. I think among doctors who provide cancer care, I think there has to be a very honest approach towards cancer, not get into fancy stuff, be realistic about what is the outcome, have a conversation with the patient before deciding on treatment. That kind of joint approach, taking the patient into confidence is something that is really going to help, because we know cancer patients, once the diagnosis hits them, it is like an avalanche hitting them. They are completely lost. And then it is very easy to sort of tell them that we have this great new medicine and this great new thing and all that. I think we need to sort of come with very honest, protocol-based, evidence-based, locally relevant things, and be honest about communicating that to the community and to the patient primarily, so that I think so I'm saying the responsibility is not just the community, because the providers are equally important and have to sort of be upfront with a very clear and direct approach to what is the situation at hand. Thank you.
Thank you. Well, we have two hands up. I think Professor Tati went first, right? So yeah, Professor Tati.
Yeah, thank you, Ben. So I agree really with what is said by friend Sonali and also Dr. Cherian. But I just want to add some. We have, Ben, we have some study saying the reason of delay in our group of patients, and we can see that we divided the delay into group: the patient's delay and systematic delay. So what I want to say is saying about what is Dr. Sonali and also Dr. Cherian mentioned. I just want to add the function of there are a lot of barrier for cancer to come to the hospital, from the socio-economic barrier, the psychological barrier, and physically a barrier, like the patient cannot walk by herself, for example. And I think, what do you think about the function of the patient navigator? The patient navigator is the what's so called the usually in our countries, in our hospital, we have a patient navigator come from the survivors group. So the survivors group, they come to us and asking to help the patient, and also so the survivors help the patient, and we train them the basic knowledge of the oncology and also how to help in the emergency situation. And we have now the system patient navigator among our patients. So the patient navigator can help the patient. And also, I agree with what is said by Dr. Sonali about the inequity, because the one patient and other patient has different barrier. So we cannot say that that's all equal. No, they are not equal. There is a specific, unique between patient and patient. So such a kind of a situation, I think, can be helped by the presence of the patient navigator. Of course, besides that, we have to take care of them very carefully. We have to talk a lot with them. We have to learn how to make the breaking the bad news and all those things. But sometimes the medical professional cannot do it by themselves. So we ask help for our friends, the survivor group, as the patient navigator. Thank you, Ben.
Thank you, Professor Tati. Yeah, and they are very helpful and they are very enthusiastic about it. Yeah, it actually is something that they like to do. That is very, very interesting and very happy to see that. So, Dr. Mossman, you raise your hand.
Yeah, I think, this whole piece about community is really important, because everybody who's on this call is busy working in cancer. So you know about it, you're aware about it, etc. But I'm not sure if you went out to the general population that they would be so aware of what the signs and symptoms are, etc. We all kind of make an assumption, but I can guarantee that if I ask any of you, what's the weather like in the town I live in, you wouldn't have a clue, because it's not of interest to you. So I think we've got to look more at how we get into the community in a culturally appropriate way. So, for example, there was work on to take information about prostate cancer to barber shops, because that's where men go. So that's where, you can have information that men will be to pick it up. There was information about cervical cancer where healthcare professionals went to women's groups to talk to them about those things, particularly in some of the cultural groups where they don't kind of go out generally and mix with other people. So I think we've got to think from the people we're trying to reach perspective rather than our perspective, and aware of them. How can we engage with them, and how can we educate them in a way that, as Sonali says, is not about stigma, but is about benefit of going forward for treatment, diagnosis, etc. So I think there's some work to be done there.
Thank you so much. Dr. Tamaki?
Yeah. Well, I think that when you really think about the community intervention, from my perspective or from the perspective of my country, I think that the approach should be about the health in general, right? It needs to start from about the health in general and approach the community. What is the concern? What will be the concern for the general public, like starting from maternal health or just the day-to-day, medical concerns of the patients. And then when you actually start developing your own health standard within your country, then it comes to the point where the cancer incidence is as high as my country, right? So when you solve all the other issues other than cancer, you tend to, end up with the issues of cancer in later stage. So I think that hopefully this cancer will not just stand by itself, but just like Dr. Sonali said, just to put cancer within the comprehensive healthcare or healthcare education, or as health literacy as a whole, is, I think, that the approach that we hopefully will have, I think. And within that, then we're going to have radiotherapy within the cancer treatment as a complete package of cancer care. Thank you.
Thank you, Dr. Tamaki. So, answering our question for this topic, considering successful in CCP, I could collect several keywords here which we have mentioned from the speakers and the panelists. I think we have heard about efficiency with the various dimensions. We have heard about sustainability, again, with the various dimensions of sustainability. We have heard about meaningful discussion involving the recipients and providers, involving various stakeholders in it. We have heard about the need for it to be comprehensive and multidisciplinary from Dr. Mossman, I think. Also about it needing to be data-driven. I think multiple panelists have emphasized the need to record not only the number, but also the performance, the cost-specific survival or other treatment outcomes as quality indicators and treatment indicators. I think those are important. So for the benefit of our audience here, do we have other keywords that have been missing? Maybe one or two keywords.
I would just really make a plea for the awareness, but really understanding the societal understanding of cancer. I think, there is a lot of more data being collected on cancer stigma. It is something that is affecting uptake, and it also finds its way into the health sector itself in the patient provider discussion. And there are some studies that are looking at that. So I would, I think we have to really understand the way that cancer is perceived. In some countries, there isn't even a word for cancer in some languages. In some members that we've spoken, there's no word for cancer itself. So I think, understanding the beliefs, attitudes, and working with those in a culturally appropriate way is important. And then having, looking at information. We do have an issue with misinformation as well, through social media, through other mechanisms, and I think it's important. So I agree very much with the two aspects. There's the society, there's the patient delay, there's the provider delay. But I would make a pitch for us to recognize the impact of stigma on health literacy and on uptake of services.
Thank you, Dr. Sonali. So stigma and misinformation need to be addressed as well. Dr. Cherian.
Yeah, thank you. I only have a small point to add. I think we have to look at system readiness. Say however much we inform the patient community, if the community person comes up with, okay, I have a lump in the breast, I'm going to the local hospital, they say we cannot do anything. You go to some 500 kilometers away in a city to do something. I will lose all trust in the system. So whenever we do create awareness in the community, we have to sort of ensure that the system is ready to take up what is happening. And in fact, most of the mistrust happens because they go to a facility and it is a facility with 500 people standing in the OPD, and I have a symptom. What will I do? So I think that is something that the providers and the governments have to seriously consider. And decentralized treatment capacity, as I have shown, radiotherapy or even pathology, where the cancer starts with pathology. How many countries have within 25 kilometers can have a biopsy done and have a definitive diagnosis of cancer, yes or no? So sometimes I think a woman who detects a lump will die with the fear of cancer rather than with cancer, because there's no way to say whether it is cancer or not. So I think we cannot shy away from the fact that in high income countries, all this has worked because there is adequate capacity at your nearest level to get a CT scan done, or a PET scan done, or an MRI done, or a biopsy done, or an FNAC done. Most of Asian countries, especially in low and lower middle income countries, this is a luxury actually. So even if a person is fully informed, it becomes quite a challenge for that person to sell the family and then go to a city which is like 1,000 kilometers away and wait there again. It is not that even in that referral center there is an adequate capacity. So I think that is something, I think Professor Tati and others, when you look at radiotherapy utilization, the distributed capacity for cancer care has to be substantial. How did cardiovascular mortality came down? Of course, reduction in smoking and hypertension. But most parts of Asia that I travel in, at least a heart attack can be treated in places now. So I think that is also, we should not forget that the system capacity is so critical for cancer compared to other diseases, because ordinary doctors just don't want to play with cancer. They will just keep referring them. Thank you.
Thank you, Mr. Cherian. Prof. Tati.
Yes, just a short thing, Ben, just to remind that what is mentioned by Jane, I think about the HTA. So it is a very important thing also, because we really have to really choosing the modality of the treatment as the priority, also based on the what we have to take into account also the patient perceive. So the value-based medicine become a very important, as we have to hear what is the patient said about one modality of the treatment compared with the other one. So I mean, even the multidiscipline team and also evidence-based is very good, but we have also to take into account the value-based medicine as well as the patient perceive. That's one about the HTA, and also partnership become a very important, and resources for the National Cancer Control Program is also very important. And about what is mentioned by Dr. Cherian, I agree with that, but we have also to take into account the geographic difficulties like what we have here in Indonesia. We consist of thousands islands, and even there is a standard like the medical treatment have to be reached by 2 hours by car, but it cannot be happen in Indonesia. That's the reason why. That's one reason, Dr. Cherian, why the actual RTU in our countries is quite low, because some of the patient cannot even, we already distributed the equipment to all the province. Even in one province, sometimes they cannot go to that facilities by car because it's still very difficult. They have to go by river or even by plane. So we cannot take into account 2 hours driving. We can reach the facility for the cancer treatment. I think that's Ben. So I just want to highlight that each countries has a unique condition that means have also to unique to solve the problem by their own. Thank you.
Thank you. So I think that wraps up some of the most important points there, and I hope that we have reached a conclusion about what are the things we need to see in our NCCP to at least predict success. And we know that there is no single best approach to NCCPs, no single approach to address all areas. This will be unique, but we need to ensure equity, as our speakers and panelists have mentioned many times during our session now. I can see that Dr. Sonali had already need to leave. And I think this is also a good timing because we have reached 90 minutes time. Sorry. Yeah. So before we close this session, if any of our speaker or panelists would like to give a few final remarks. We can just start with Dr. Jane Mossman.
Yeah, I just wanted to kind of make a comment that there is a lot to be done, but to make it happen needs leadership. And I think the fact that you are working to develop strong leaders in the radiation oncology field is a really important step. And I would encourage you to kind of work with those leaders in the different countries to take a strong role in the development and delivery of the national cancer control plans, because there's no doubt that radiation oncology is critical in cancer care. So I think, my closing comment is over to you.
Thank you. So FARO has a great work ahead. Dr. Tamaki.
Yeah, just concluding comment. Just like the issue of access is very tricky, whether to establish centralized system or whether to provide the care to the wider community in a proximity that they can travel. I think that the approach that we need to take is realistic and down to earth and really what suits each situation. But at the same time, it also needs a big picture, just like that Dr. Cherian and Dr. Tati has laid out. He starts off with the realistic environment, but with the vision of the ultimate goal that we're aiming for. And I think that's what's needed in the region of Asia. Thank you.
Right, that's great. So again, I think it's time to conclude our session. I would like to thank everyone attending, particularly to both our speakers, Dr. Cherian Varghese and Dr. Soehartati Gondhowiardjo. Thank you so much for sharing your perspective and experience. And also to our three panelists here, Dr. Tamaki, Dr. Jane Mossman, and Dr. Sonali. Again, thank you so much for sharing additional perspectives, which rounded up our discussion this afternoon. I really hope that our participants will find this useful in the future when they are involved by the Ministry of Health or other parties nationally in the development or improvement of the National Cancer Control Program, ultimately to the benefit of cancer patients in our region. So again, thank you so much. And I wish you all a nice day, a nice evening. Thank you for joining our FARO webinar today.
Thank you. Bye-bye.
Thank you.
Thank you so much.
Oh, wow. Thank you. Bye. See you.